Good evening. I'm Daniel Morin, a cardiac electrophysiologist at the Ochsner Medical Center in New Orleans, Louisiana, and senior consulting editor for circulation, arrhythmia, and electrophysiology. On behalf of our editor-in-chief, Dr. Paul Wang, who's with us tonight, I'd like to welcome you all to today's Circulation A&E webinar on cardiac implanted electronic devices, specifically looking at ongoing risk stratification for ICD therapy. We've done several of these webinars now, and every one of them has been excellent. I'm sure this will be no exception. I'd like to turn it over now to our moderators, Drs. Jordana Kron and Parikshit Sharma. Guys, take it away.
Thank you so much, Dan. So we're delighted to be here tonight with a very exciting and relevant topic, assessing and reassessing ICD benefit and risk. I'm Jordana Kron, an associate professor of medicine at VCU, Virginia Commonwealth University in Richmond, Virginia. My co-host tonight is my friend and colleague, Dr. Parikshit Sharma, and he is associate professor and section chief of EP at Rush Medical Center in Chicago.
Well, thank you everyone for joining. We have an excellent panel of speakers here tonight. These are leaders in the field of cardiac implantable devices, and we'll be here sharing some of their latest research as well as insights into some of the challenging decision making surrounding ICDs. So to ask a lot of questions, post your questions in the chat box, and hopefully we can make this hour worthwhile and learn a lot from our distinguished panel speakers.
So as I introduce our speakers tonight, you'll realize we really have an international panel with people who have trained all over the world. Our first panelist tonight is Dr. Matthew Yuyun. He obtained an MD degree in Cameroon and then received a Commonwealth scholarship to continue his training in the UK at the University of Cambridge, where he received degrees in biostatistics, epidemiology, and a PhD in cardiovascular epidemiology. He's now joined the VA Boston healthcare system as an attending cardiac electrophysiologist and general cardiologist, with an appointment as instructor of medicine at Harvard Medical School and adjunct instructor in medicine at Boston University School of Medicine. He'll be presenting data from his recent publication in Circ A&E, ongoing risk of ventricular arrhythmias and all-cause mortality at ICD generator change. Also joining us tonight on the panel is his senior co-author, Dr. Jagmeet Singh, MD, PhD, who is a professor of medicine at Harvard Medical School and founding director of Resynchronization and Advanced Cardiac Therapeutics Program. Dr. Singh is a national and global principal investigator on 5 ongoing multi-center clinical trials in device therapy for heart failure and for catheter ablation for atrial fibrillation. We're delighted to have you both with us here tonight.
Thank you, Jordana. Thank you for the invitation.
Thank you. Is everyone seeing my screen?
Yes.
Okay.
Yes, we are.
So thanks, Dr. Kron, Dr. Wang, Dr. Sharma, and Dr. Morin for organizing this webinar and for inviting me to present and participate in discussions surrounding this area where there's still some clinical equipoise about what to do in patients who present for ICD generator change with a recovered LV systolic function. The title of my talk is Assessing and Reassessing ICD Benefit in Patients with Recovered LV Systolic Function at ICD generator change. I have no disclosures. Our interest in this area was triggered by a case report which we published last year in Jack case report. It was about a 57-year-old gentleman who initially presented to our institution in 2005 with non-ischemic cardiomyopathy and subsequently received a primary prevention ICD. He was followed up, and during the follow-up period, his LV systolic function normalized and was 65% 7 years after the initial implant at ERI. He had had no prior therapies. The discussions were carried out with him about the benefits and risks of an ICD generator change, and he did not want to proceed, so he declined. He was lost to follow-up from both the cardiology clinic and the device clinic, and then in 2017, which was approximately 5 years after his ICD had reached ERI. He presented back to our institution following a syncopal event with chest pain in the setting of an acute coronary syndrome. While in the coronary care unit, he went into ventricular arrhythmia storm and received appropriate ICD therapies. Surprisingly, it remains unclear why his ICD battery voltage was able to discharge appropriate therapies 5 years when he had supposedly reached ERI. When we interrogated his device, in addition to the now arrhythmia storm that was probably due to an ischemic substrate, we realized that in 2016, he had had a shock. And in 2015, he had had further therapies. Nobody knows whether he would have still been alive if his ICD had truly died. And this was happening when his ventricular arrhythmia substrate was supposedly non-ischemic and his LV function was fully recovered. During his admission in 2017, he had cardiac catheterization, which showed tight LED stenosis, for which he received drug-eluting stents. Echo showed LVEF of 65%, and we carried out the generator change and discharged him with an antiarrhythmic medication, favoring sotalol over amiodarone because of his age. It is because of this case that we felt the need to review the literature for evidence and guidance about what to do in patients like him who present for generator change and are noted to have fully recovered LVEF. I'm projecting this slide, which is familiar to all of us, just to celebrate the evidence that accrued in the late 1990s and early 2000s from landmark clinical trials showing that ICD use was associated with significant reduction in mortality, both in primary and secondary prevention settings, especially in ischemic cardiomyopathy. It is worth noting that these trials recruited patients and they had very stringent inclusion criteria when it came to LV systolic function. Based on the positive findings from these trials, many guidelines sort of included it in their recommendations. And I'm showing here the American guidelines from 2013, then the European guidelines from 2015, and then the most recent American guidelines from 2017. While all of these guidelines clearly depict classes of recommendations for both primary and secondary prevention, ICD implantation, they fail to provide clear recommendations about what to do with patients who present a generator change with either a partially recovered LV systolic function or a fully recovered LV systolic function. It is worth noting that many implanters continue to carry out generator change in this group of patients. There are currently no clinical trial data to support whether to change or not to change in this group of patients. So in the light of this uncertainty, myself, some of my colleagues, and some of my mentors, including Dr. Jagmeet Singh, who is one of the panelists, decided to carry out a systematic review and a meta-analysis that was entitled Assessing the Risk of Appropriate ICD Therapies and All-Cause Mortality After Generator Change in Patients with Improved LVEF, no longer meeting primary prevention guidelines criteria basis on improved LVEF for patients without versus with prior appropriate ICD therapies during the life of their first generator. So we systematically searched PubMed, MBES, the Kron library, and we had about 700 citations. After applying the usual inclusion and exclusion criteria, as well as quality assessment, we retained 15 studies comparing outcomes in patients with improved versus unimproved LVEF, as well as 8 studies comparing outcomes in patients with prior and without prior ICD therapies. So our first results are ventricular arrhythmia risk in patients with improved LV systolic function greater than 35% versus those with unimproved LVEF. We saw that the pool annual incidence was significantly lower in the improved group, and this is borne out here in the meta-analysis in this forest plot on the right, where there was a relative risk reduction of about 50% favoring the improved group. While we see this significant relative risk reduction in the improved group, and we see that the absolute risk was reduced by about 6%, you see that even in the improved group, there was still a residual risk of about 4.6%. When these analyses were restricted to primary prevention ICDs only, we had similar results. So the absolute risk reduction was about 6%, and then the relative risk reduction again was about 53%. When we looked at inappropriate shocks, there was no difference between the two groups, as seen here in the meta-analysis where the confidence intervals cross the line of unity. And then next, we looked at all-cause mortality. And again, there was a significant absolute risk reduction of about 4.3% in the improved LVEF group compared to the unimproved group. And this again was borne out in the meta-analysis that we see here. There was a relative reduction of about 35% in favor of the improved group. But if you look again, there was still a residual risk here of 6.6% per annum, and this is per annum. If these people have to live for like 10 years or more, then imagine the cumulative risk. The cumulative risk, sorry. Next, we decided to look at ventricular arrhythmia risk in patients who had not had prior therapies from their first ICD versus those who had had prior therapies from their first ICD. And what we saw was that there was a significantly reduced absolute risk in favor of those without prior therapies, as shown here in this meta-analysis, where there was a 63% relative risk reduction in favor of those without prior therapies. But you still see that there's about a 4% residual risk here in those without prior therapy. So the risk is not infinitesimal. In conclusion, from that particular paper, what we found was that at generator change, about 25% of patients had their LVEF improved to beyond guidelines recommendations. Approximately 2/3 of patients did not receive therapies from their first ICD. Most significantly, we noted that there was a significant absolute and relative risk reduction of ventricular arrhythmias in improved LVEF for those without prior therapies compared to the latter groups. However, what we also observed was that there remained a substantial residual risk of ventricular arrhythmias and death in patients with improved LVEF for those without prior therapies. A few more slides. Just in a similar vein, we conducted a meta-analysis titled Risk of Ventricular Arrhythmias in Cardiac Resynchronized Stent Therapy Responders and Super Responders that was recently published in Eurospace. Titled, the aim of this particular meta-analysis was to determine the impact of CRT response and CRT super response on risk of ventricular arrhythmias and all-cause mortality. I'm just going to show 2 slides from the ventricular arrhythmias and then stop. You look here, when you compare CRT responders to non-responders, the absolute risk reduction was about 5.5% per annum. And the meta-analysis of that data showed that there was a relative risk reduction of about 53% in favor of CRT responders. But again, you see here, there was still a residual risk of about 4.5% per annum, which is not small. And then when we look at the risk in super responders versus non-super responders, what we found was that super responders defined as LVEF of greater than 50% had a significantly lower absolute risk of 0.9% compared to 3.8%. And this again was evident in the meta-analysis here in this forest plot on the right, where there was a relative risk reduction of about 78%. So that is that, and I will end here. Thank you. Any questions on this?
So we certainly welcome any questions in the chat function. So please jump on and send in some questions. But I have one question to start. How do you think that treating physicians should sort of incorporate this data into their practice? How do we use this to further our discussions with our patients and try to personalize the care for them to help them make decisions around the time of generator change?
So thank you very much, Dr. Kron. Without clinical data to back things up, this kind of observational data does give us something to work with. What we found was that in patients who showed up at generator change, if their LVEF was improved beyond the guidelines recommendations, there was still some significant residual risk. And if they had probably a life expectancy of greater than maybe a year, and then it would not be completely absurd to change their ICD in terms of patients with ICD. For CRTD patients, if their LVEF, because the absolute risk was very small in the people whose LVEF had improved greater than 50%, maybe if they presented in that scenario, it might be worthwhile having discussions about a possible downgrade of the CRTP possibly. But what we have to remember is that there's no data out there for just the just the ICD population above with an LVF of above 50% to make recommendations. We found only 2 small studies where the risk was very infinitesimal, but it's very hard. And if you look at the case report that we presented, that guy had an LVF of 65% at ERI, which remains at 65%, even though the substrate of his arrhythmia changed from non-ischemic to ischemic. So I think the risk restratification and carrying out discussions about is there potential for ischemia in the pipeline, how old the patient is, what their symptoms are, is worthwhile. And then giving them the risk of ICD generator change, which is about 4% of major complications, something like that.
Great, thank you.
Jordana, can I ask a quick question if we have time? So, Dr. Yuyun and Dr. Singh, thanks for that phenomenal analysis. The interesting thing to me is that we still haven't been able to completely tease out what is the pathophysiological mechanism. Did any of these studies really have data on things like cardiac MRI, or are there specific subsets of patients with specific type of cardiomyopathies that might be at an additional risk or a lower risk once their ejection fraction improves? And is the EF in and by itself sufficient to help risk stratify that? Any thoughts on that?
Matthew, that was a terrific presentation. Thank you for that, and amazing work. I'll say one thing, our ability to risk stratify is so primitive, trying to use a single solitary covariate as ejection fraction. And we know that arrhythmias are a dynamic event, right? They are an interplay between a substrate, a trigger, and the autonomic milieu. And we know that all of these 3 things can be so variable and dynamic that using baseline risk stratifiers are really suboptimal, but that's the best we have. So to answer the first part of your question, did these studies have data? They probably did individually, but not enough collectively for us to parse out. And I think that's the important question that I think webinars like this are going to raise, that we all need to collate our data sets to really have finely granular data that we can then parse out and use machine learning to help risk stratify our patients better. So unfortunately, we're back to the ejection fraction. And I think the beauty of this work is that it at least gives us some information to have a better discussion with the patient to better individualize our care. So for example, if you have an 85-year-old patient who had no arrhythmias in the past, and now their ejection fraction has improved from 35 to 50%, you can have a different conversation with them saying, hey, you got 2 major predictors out here that the likelihood of you having a shock in the future is lower. Maybe we can do without a generator change. So I think we can use information to arm ourselves to individualize our care, but we cannot use it across the board as a cutoff to say yay or nay for a device.
If I could just add something, we've experienced something recently where we have patients who have had ejection fractions that have improved over the course of their first defibrillator. And then when it comes time for a generator change, well, we perform the generator change if that is what the patient desires. But then we've had some pushback from the insurance companies saying that the patient no longer meets criteria for ICD implantation. And I'm wondering if we could use some of these data as evidence or arguments, sort of contra the insurance companies' arguments, or do you think we need ongoing research, or do you think we need no more at all?
So that's a really good point, Dan. So one, I think we can, at this point in time, use this data, use these publications to arm ourselves for an argument saying that it's not possible to clearly predict that they're going to be free from arrhythmias in the future. But at the same time, I think we all know that the science is heading in a way that we'll have to use more than one covariate to risk stratify patients in the future. Now, are we in a position to do more studies to do that? I think we are, but I think for the industry to sponsor randomized clinical trials to reduce the number of devices that are implanted in the future is going to be very challenging. And I think it's going to be large registries that have continuous data, that are prospective, that use machine learning strategies to help substratify patients into different kinds of clusters than just EF of 35 and lower, are the way the future is going to evolve. And I think we're going to have to work together to be able to do that.
Yeah, I don't think I have anything more to add to what Dr. Singh says. I think in an ideal world, there are two ways that you can answer this question. You can either carry out a new clinical trial where you can look at people with EFs of 35% to 50 without devices and then randomize them and see whether there is clinical benefit. That's one way of doing it. For people who present for generator change, you don't change that generator in half and you change in half and then study outcomes in future. The latter one might be slightly unethical in the face of what our data has shown, but in the absence of clinical trials and maybe the energy from device companies to support this kind of initiative, I think registry data, as Dr. Singh has mentioned, and the results of our meta-analysis do say that maybe in certain categories and you can re-stratify, although we don't have very concrete variables to use as re-stratifying factors. It just has to be individualized to each specific patient.
Right.
All right. Well, thank you, Dr. Yuyun and Dr. Singh, for that beautiful presentation and work. Next, I have the pleasure of welcoming Dr. Ethan Rowan. Dr. Rowan is the Associate Director of the Hypertrophic Cardiomyopathy Center and the Director of the Cardiac MRI at Tufts Medical Center. His clinical interests focus on the management of patients with hypertrophic cardiomyopathy and advanced imaging. And his research interests focus on leveraging the large clinical hypertrophic cardiomyopathy database he has helped create and help improve the understanding of the natural history and outcomes amongst these patients. Dr. Rowan is the first author of a Circulation, Arrhythmia, and Electrophysiology paper published in 2020, which is titled The Long-Term Outcome in High-Risk Patients with Hypertrophic Cardiomyopathy After Primary Prevention Defibrillator Implants. I also have the distinct pleasure of welcoming his senior co-author, Dr. Barry Maron, who really does not honestly need an introduction. He is considered the father of hypertrophic cardiomyopathy research, has spent 40 years investigating this genetic disease, authored over 900 articles on this topic. He's the director of the clinical research in the Hypertrophic Cardiomyopathy Center at the Tufts Medical Center in Boston. And I would like to welcome both of you guys to present your work and have an intellectual discussion on this very interesting topic. Thank you.
Thanks so much for choosing our article and inviting me to present it today. The ICD initiative for primary prevention of sudden death in HCM now spans for over 20 years, really stemming from Barry Maron's New England Journal of Medicine article in 2000, in which he showed that the ICD can effectively terminate these potentially lethal ventricular arrhythmias in a heterogeneous disease like HCM. Over this period, risk stratification has matured, really contributing in large part to the reduction in HCM mortality, which is now 0.5% per year. In that regard, many young patients with HCM have now survived with ICDs for over a decade. But the frequency of ICD interventions and the burden of device complications in HCM over this type of substantial period of time really remains unresolved. And therefore, the purpose of our study was really to determine the outcomes specific to HCM patients with ICDs for at least 10 or more years of time. So in that regard, we have over 200 HCM patients who had their ICD implanted at Tufts before 2008, and therefore allowed for over 10 years of clinical follow-up. Relatively young patient cohort, average age was 38 at device implantation, and our subset of patients were followed for an average of 12 years from device implant. So what led to device implant in this subset of patients? So the majority had the traditional risk markers established at that time for markers for sudden death in HCM, including family history of sudden death, unexplained syncope, NSVT, massive hypertrophy. Less common were the novel risk markers, which are included in the current HCM guidelines, and really shows the evolution of risk stratification, even over a 10-year period, with risk markers now including end-stage HCM with systolic dysfunction, LV apical aneurysms, and extensive LGE. What led to device implant? About 2/3 of patients had a device implanted for one risk marker, 25% for two risk markers, and about 10% for 3 or more risk markers. So what happened to these 217 patients? 21% had one or more appropriate ICD intervention for rapid ventricular tachycardia, or VF. About the device intervention occurred about 7 years from device implant. And notably, 12 of these 45 had multiple appropriate ICD interventions, with the time period from first to second intervention averaging about 3 years. There's long been controversy about whether or not, particularly back in 2008, one risk marker was enough to implant a device in HCM. And we really found no difference in appropriate therapy in patients with 1, 2, or 3 risk markers. So one risk marker is definitely enough for device implantation in select patients. When did the appropriate ICD therapy occur? So in about 11% of the patients with appropriate shocks, it occurred in under a year, about 25% between 1 to 4 years, which means that in nearly 2/3 of patients, the initial appropriate ICD therapy occurred over 5 years from device implant, including 36%, which occurred 10 or more years after decision for ICD implantation. And that really leads to an important principle in HCM, which is that using AHA-ACC risk assessment, it's not really just for the short term, but you're really looking for sudden death risk over extended periods of time, with timing of these events being unpredictable. So next, wanted to look at one of the big controversies between the US and the ESC in terms of risk stratification, with the ESC supporting the Esc Risk Score to identify patients with events. Those of you not familiar with the Esc Risk Score have to realize that it's dramatically different from the AHA-ACC guidelines in relation to risk stratification. They use this mathematical formula that includes several traditional risk markers, including maximum wall thickness, family history of sudden death, NSVT, and unexplained syncope. But they also add risk markers not included in the AHA, including left atrial size and LV outflow gradients, which are characteristically dynamic. You impute those patient characteristics into the risk score, and it then tells you this patient is high risk, where an ICD should be considered, intermediate risk, where it may be considered, or low risk, where an ICD generally is not indicated. So we wanted to go back in our patients with appropriate ICD events and look at the Esc Risk Score at time of device implementation. This is what we found. 42% of patients were considered high risk by Esc Risk Score. But 36% of patients with appropriate ICD therapy were considered low risk and excluded ICD, missing the opportunity for sudden death prevention in those patients. That being said, the Esc Risk Score is looking at 5-year risk for sudden death. And we had 29 patients who had delayed appropriate ICD interventions. So we then went back and recalculated Esc Risk Score just before the appropriate ICD intervention. And surprisingly, we found that the Esc Risk Score in these patients actually decreased. And thereby, almost 60% of patients with appropriate ICD interventions would have been considered low risk just prior to an appropriate ICD therapy. So moving back to our cohort of patients, obviously we can't just talk about benefit of ICDs over long periods of time. We also need to discuss potential ICD complications. And in that regard, inappropriate shocks did occur in 18% of our cohort. Notably, 7 of these patients, though, also had appropriate interventions. This is looking at timing of ICD complications with inappropriate shocks in blue. And you can see that most inappropriate shocks occurred within 5 years from device implantation. How about major device complications, predominantly related to leads? They occurred in 27 patients, 12% of our cohort. Most commonly lead fracture and infection, and that's in red on this graph. And you can see that the majority of those occurred after 5 years from device implant, not surprisingly. But notably, in this young patient population, there was not an exponential increase in major device complications, at least over this 10-year period follow-up. So let's look at rate of appropriate ICD interventions and inappropriate ICD interventions over time, with appropriate ICD interventions here in blue, inappropriate in pink. You can see that appropriate ICD interventions rate increased over time, while inappropriate ICD interventions decreased with time. In large part, that's probably because of the major impact of the MADE-IT trial, within 2012, which would fall to around tier in this timeline for most patients. We systematically changed our device settings, and that's probably in large part responsible for our decrease in inappropriate shock rate. But nevertheless, at the same time point, we still see an increase in appropriate shock interventions in HCM patients, despite change in ICD settings. So how about mortality in our over 200 HCM patients with ICDs over 10 years? And you can see excellent overall survival, 96% alive at 10 years from ICD implant. You know, ICDs in HCM really differs from other populations. In other populations where appropriate shocks been associated with increased mortality, none of our patients with appropriate ICD therapy died over our follow-up. And there was no difference in mortality rates in patients with ICD complications and with those without events. In addition, looking at end-stage heart failure in HCM, uncommon occurrence, and with ICD therapy, not increasing risk for end-stage heart failure as compared to those patients with ICDs and without appropriate interventions. So I think several key takeaways from this cohort. One is that the ICD is effective in preventing sudden death in HCM and allows for very low HCM mortality over long-term follow-up periods. Timing of an appropriate ICD therapy for VTVF is unpredictable in HCM, with 2/3 of events occurring over 5 years from time of risk stratification and ICD implant, and including 1/3 occurring after 10 years. So AHA-AC risk stratification is really for a long-term risk for sudden death. Appropriate ICD therapy was not associated with increased mortality in HCM. Esc Risk Score does not accurately identify patients with sudden death events, nor predict the timing of these events. And frequency of inappropriate shocks have decreased over follow-up, which likely reflects standard changes in device programming during the study time period. Thank you.
Well, thank you so much, Dr. Rowan. That was a beautiful presentation. I particularly enjoyed the comparison with the ESC guidelines and their risk stratification, because I think that's very valuable information. This is probably the largest cohort with the longest follow-up, and it gives us much more insight into this disease process and the risk of sudden death. So from a very general perspective, how do you guide patients or other providers that come to your institution as sort of the pioneer when it comes to a lot of the research with hypertrophic cardiomyopathy? What sort of messages does a study like this offer to patients in terms of risk stratification and guidance? And the one additional thought that comes to my mind is, what do you believe is the value of gadolinium enhancement, which I think has been talked about a lot with some data in the last few years with regards to benefit with risk stratification in this cohort of patients?
Yeah, great question. You know, not assessed in this study, but data that we recently published looking at our cohort of over 2,000 HCM patients, published in JAMA Cardiology last year, demonstrated that the current ACC-AHA guidelines have 95% sensitivity for detecting HCM patients with sudden death. So in that study, we only had 5 patients who died suddenly, and only 3 of those did not have risk markers out of 2,000 patients. So I think my takeaway message to HCM patients is that our risk stratification really allows for very high sensitivity, allows identification of patients with events. Over follow-up, our number needed to treat in that study was a little over 6 patients. So 6 patients with ICD placed for 1 sudden death event. Obviously, that still means some overimplantation of device, but this study really suggests that that overimplantation might be even lower when you consider that the majority of events were late. To answer your second question as it relates to extensive LGE, which we really consider as a strong risk marker in HCM. And we're not talking about just presence of LGE, which is way too common, present in over 60% of HCM patients to use for risk stratification. We're talking about amount of LGE quantified, and with large burden of LGE, strong risk marker associated with twofold increased risk for sudden death in HCM as opposed to patients with no LG. That is for both appropriate ICD therapy, and we do offer patients devices based on extensive LGE, but also identifies patients at risk for end-stage heart failure and systolic dysfunction.
Thank you so much. Really just fantastic work. Congratulations to you and your team.
Thank you.
So now we're going to introduce our third and final panelist, Dr. Theophany Mela. She's a cardiac electrophysiologist at Mass General, an associate professor of medicine at Harvard Medical School. She's been the director of the Mass General ICD and Pacemaker Clinic since 2003. She was born in Athens, Greece, and graduated from the University of Athens Medical School. And she's done her training in New York City and Boston, and ultimately ended up at Mass General. She has a lot of clinical and research interests in sudden death, lead extraction, and device therapy, and she's published extensively in these fields. Tonight, she's going to be discussing CRTD versus CRTP. Thank you for being with us here tonight.
Thank you so much for the invitation. And as we discussed earlier, because of technical issues, I would ask you to advance my slides if possible. I think Mass General is going to need to buy a new computer for me, but we will try to do this together. So my topic today, CRTD versus CRTP, and how we decide how we have the best decision for our patient. If we could go to the first slide. So the evidence from randomized clinical trials is insufficient to help us decide on this significant question. What do the guidelines say? If a patient is going to be getting an ICD and CRT is recommended, then the indication is 1A indication. But if a patient is a good candidate for CRT, the decision of whether that should be CRTD or CRTP is a class 2A indication for the defibrillator implant. The European Society guidelines in 2013 tried to give a way to guide us in this decision. So factors that could favor CRTP could be advanced heart failure, severe renal insufficiency or dialysis, major comorbidities, frailty, cachexia. Factors for the CRTD, life expectancy more than a year, stable heart failure, NYHA2, ischemic heart disease, and lack of comorbidities. So overall, patients who get CRTD may benefit from a mortality reduction, whereas with CRTP, there is higher mortality. But when we talk about complications and costs, CRTP has a better profile. Going to the trials that gave us knowledge about the answer to this question, of course, the pivotal companion trial, when the primary endpoint and what that trial was, the comparison of patients who were getting CRTD, CRTP to optimal medical therapy. The primary endpoint, which was death from or hospitalization from heart failure, was reduced by 34% in the pacemaker group and 40% in the ICD group, whereas the secondary endpoint, death from all cause, was reduced by 24% in the pacemaker group and 36% in the ICD group. But the trial did not really compare the outcomes in the CRTP versus CRTD groups, and only a few years later, an analysis by independent authors actually suggested that there was no difference between the two groups. The Theofanie trial also gave us knowledge about the use of ICD in non-ischemic cardiomyopathy. So patients with EF less than 36% and increased ventricular ectopy received ICDs versus optimal medical therapy. They were followed for up to 2 months. The primary endpoint, annual mortality, was not reached. It was similar in the two groups, whereas arrhythmic death was, of course, better in the ICD arm. And we can see here the two the graphs, the main graphs of the study, death from any cause and sudden death in the two groups. The Scott Half trial was really the one that put the basis in all our contemporary practices, compared patients with ischemic and non-ischemic cardiomyopathy to placebo or amiodarone. And of course, we know the results showed that ICD was beneficial overall for the group. But in the next slide, we'll see that when the question was looked in the non-ischemic group, which was about 50% of the study, there was actually not significant difference between optimal medical therapy and the ICD group in terms of mortality. Finally, the Danish study was the one that really emphasized the question of whether ICD improves the survival in patients with non-ischemic cardiomyopathy. So primary endpoint was death from any cause. Secondary endpoint was sudden cardiac death and other outcomes. And what we, the patients were the patients with ejection fraction less than 35% and heart failure. And if we go to the next slide, we will see that they were not only optimally, and if you can advance with a couple of clicks, not only on optimal medical therapy, but they also had received CRT to a great percentage, 60% almost on both groups, the one that received ICD and the one with optimal medical therapy. We will see in the next slide, and if you hit a couple of times, we'll see that there was no difference between the groups for death from any cause, cardiovascular death, and even hardly made the difference for sudden cardiac death, understandably so, but the overall mortality was not different in the two groups. And if we go to the next slide and hit a couple of times, we will see that sudden cardiac death, of course, was better in the ICD group. But when we look at the complication rate, device infection, and inappropriate shocks, of course, there was a worse outcome in the ICD group. If we go to the next slide, the only group that was benefited from ICD therapy was younger patients less than 59 years of age in the non-ischemic cardiomyopathy group. Subsequently, we have a pause in terms of obtaining data from randomized controlled studies, but we have a significant amount of data from registries and observational studies. And Certitude was one large observational study. Almost 2,000 patients were enrolled between 2008 and 2010 in French centers, and they looked at the practice of physicians in terms of utilizing CRTP and CRTD, and we will see about 30% of patients got CRTP, and we can see the average age of the patients, the percentage of women. And if we go one slide further, we will see in red what the majority of the patients that received CRTP represented. So they were older. In red color, they were more women, higher level of comorbidities, more dilated cardiomyopathy, more advanced heart failure class, wider QRS, and more atrial fibrillation. And if we go to the next slide, we will see that, of course, all-cause mortality on the top diagram was higher in the CRTP group, because we already know that they were older and sicker patients. But looking at the sudden cardiac death, actually there was no difference between CRTP and CRTD, a quite striking result. In the next slide, similarly in the Medicare study, which looked in 5% a random sample from Medicare beneficiaries between 2007 and 2014, who received, according to their physician's decision, CRTD versus CRTP. These were about 5,500 patients. All-cause mortality was not different. Any hospitalizations were not different. Even cardiac hospitalizations were not different. In a similar registry that took place among 200 centers in Europe, if we go to the next slide, they involved about 10,000 patients. Again, the percentage of CRTP patients were about 30%, 40 countries, favoring CRTP, similar factors as we saw in the Certitude study: advanced age, female gender, non-ischemic cardiomyopathy, sicker patients. And if we go to the next slide, we will see an interesting phenomenon of some significant variability from country to country. Some countries that do not hardly use any CRTP devices, and others that use them for almost 90% of their CRT patients. Going to the next slide, we will see some arguments against using I'm sorry, this actually I have a different order in the deck that I use. Staying on this slide, actually this was a proposed score system to help physicians decide between CRTD and CRTP, and of course going through a list of risk factors to risk stratify patients accordingly. We will go to the next slide, and here we will talk about issues with unnecessary implantation of an ICD, and we know higher risk for infection, lead-related issues, procedural issues, inappropriate shocks, PTSD, and overall ICD implant itself exposes a patient to a 6% risk of major complications. And if we go to the next slide, just a reminder about the Replace study from almost 10 years ago now that showed a significant complication incidence in patients with upgrades to CRT or ICD, and patients with ICDs, and overall up to even 15% complication rate. So what can drive our decision between CRTP and CRTD? It's a multifactorial decision that has to do with patient expectations, physician's experience, risk stratification, and cost effectiveness. In the next slide, I will talk for a second about a meta-analysis that we had performed a few years back, trying to answer the question of whether, when at the time of replacement, an improvement of the ejection fraction following CRT implant could make us decide to implant more pacemakers and replace with fewer ICDs. Again, the patients with primary prevention indication for ICD, regardless of a left ventricular ejection fraction recovery definition, had very low rates of ICD therapy, but that rate was not zero. So again, some insecurity there. In conclusion, CRTD or CRTP, I try to answer these questions. There should be personalized consideration for each patient. We need prospective randomized trials to answer the question conclusively. ICD mortality benefits need to be reassessed in the era of new heart failure regimens. We need to study the removal of ICD from CRT devices when the ejection fraction is improved at the time of replacement. And again, in the next slide, the final summary of ESC and my proposal customization of our decision for each patient. And as a final slide, thank you very much for your attention. And thank you very much for moving my slides in such an efficient way. Thank you so much.
Thank you so much. That was fantastic. One question I have is, are there certain patient populations where you tend to stay with a pacemaker rather than an ICD, even when the EF is low? For example, tachycardia-induced cardiomyopathy in someone who you think if you control the AFib, that EF is likely to improve, or other cohorts where you really sort of lean towards pacemaker implantation?
Very good question. And again, it's a personalized decision with every patient. I agree with you. When we have the expectation that the ejection fraction is going to improve, we stay with the pacemaker. Tachycardia-mediated cardiomyopathy is one example. Pacing-induced cardiomyopathy is another, when there's no other identifiable cause for the reduction in the ejection fraction. I have to say, though, that it's always a tough decision, thinking that you don't want to do this procedure again a few months later.
Great.
Thank you, Dr. Mela. So, I often wonder, on the flip side to that conversation is, if you have a patient that you talk about the pros and cons of implanting a CRT defibrillator, and now their ejection fraction is completely normalized, let's say very quickly, very rapid responder to CRT therapy. What's your take in those sorts of patients? And this sort of ties back into the first talk of downgrading them back to a pacing system as opposed to an ICD if they request for the same.
Yes, in my practice, and I always advocate when I teach the fellows, for at least having the discussion with the patient. I have found that the result, the final decision is variable, and many times has to do with a patient that may or may not feel insecurity when you ask them to give away their ICD that in the past we had advertised as their angel, their guardian angel. So I always have the discussion with the patients, and my preference is usually to downgrade for the reasons that we discussed before: infection rate, complications with ICDs, but the very final decision is also up to the patient, and that makes it sometimes a harder decision.
Okay, do we have any questions in the chat? Let's take a look.
Haven't seen any pop up as of yet. So.
Okay. So one question I wanted to ask for Dr. Rowan. So one issue with trying, certainly for young patients, we need to take that long-term perspective. It's really a marathon, not a sprint, but we're using the risk stratification at one point in time. Do you think that that is part of the challenge, that we're using risk markers on day one and then trying to predict what's going to happen over 10 years in somebody who's a young hypertroph?
Yeah, it's a great question. I think that, it's pertinent in two ways. One is, someone who has syncope 10 years ago, is that still a risk marker for them with that device implant? And I will say that we've had late shocks in those patients as well. So it's really challenging. The second part to that is the opposite. In someone who you initially consider low risk, you're not done with that assessment, and does need to be continued on an annual basis to see if their risk profile changes.
Great, thank you.
Dr. Singh, yeah, go ahead, Jordana.
And I was just going to say thank you so much to our panelists tonight. We really, gave us a lot to think about in terms of trying to help our patients make really good choices when we have to decide whether they need a device initially, or when we're deciding whether they need to continue to have a device. You've all really done a great job tonight. Thank you so much for being here.
Well, again, thank you to all of our expert panelists. These were all phenomenal talks with great work that we're all getting to learn a lot from and getting an opportunity to prick your brains for our sake as well as our audience. So thanks a lot. I also want to thank Christina. She's been an amazing support through all of these webinar series and really keeping this process going in a smooth fashion is really critical. So thank you, Christina. And again, finally, thank you both to Dan Morin and to Dr. Paul Wang for your continued leadership and guidance through the journal and outside. So thanks a lot.
Thank you. Thanks, everybody. Have a great night.
I think just final announcement, join us next month for our next CircA&E webinar on athletes and ICD lead failure and remote monitoring. So looking forward to that one next time. Have a good night, everyone.
Thank you.
Bye.
Good night.
Good night.
Bye now.